is the second part of the video, HIV infection with AIDS and Pneumocystis pneumonia. We continue with the video.
That was great. Do you think you could try it again?
I don't think so. That really wore me out.
That's okay. It's all right to rest in between all the activities, but in order to clear the secretions and get you breathing a little bit easier, it's going to be important that you try to use this at least 10 times per hour while you're awake. Do you think you could try that?
I'll try.
Excellent. I'm just going to check your IV now.
When assessing the IV site, check for redness, edema, or drainage. Any of these findings is an indication that the IV site should be changed.
Do you have any pain or discomfort here?
No, none at all.
Great, and you're receiving D5 half normal saline at 100 milliliters per hour, just like you're supposed to. So your IV site looks great. There's no redness, there's no swelling, and there's no tenderness, and your IV fluids are great. So I'm just going to write that down. If at any point your IV starts to bother you, let me know right away. It's very easy for me to change it, okay?
Okay, I'll let you know.
For some patients, your gastrointestinal assessment will include looking at their nutritional intake along with physically assessing their abdomen.
Ms. Robbins, how has your appetite been?
I haven't really eaten these past few days. I've just been too tired.
So you've been too tired to even eat? Okay. It's going to be really important right now to keep up your calorie intake and also to keep adequate nutrition because you're going to be burning a lot of calories during the healing process, and we really don't want you losing any weight right now. So if you prefer, I can bring you small, more frequent meals. This should help with how tired you get when you eat. But don't worry, as soon as your condition improves, your fatigue will improve also. Okay?
Okay.
For patients who are dyspneic, it's important to plan rest periods before any meals and to facilitate small, frequent meals for the patient. This will make it easier for the patient to meet his or her nutritional needs. As we move into the second part of this gastrointestinal assessment, you'll be listening in the 4 quadrants of the abdomen for positive bowel sounds, checking for hyper or hypoactivity. After listening to all 4 quadrants, lightly palpate the stomach, looking for rigidity, firmness, or tenderness.
Now I'm going to assess your abdomen, and what I'm going to need to do is put my stethoscope underneath your gown to listen.
Okay, but what are you listening for?
The stomach and intestines make gurgling noises, and those tell us that they're functioning properly. But I'm going to put the head down first a little bit. Good. I hear sounds in all 4 quadrants. Now I'm just going to palpate your abdomen, and I'm looking for any rigidity, any tenderness, any firmness. Does this bother you at all when I do this?
No.
Great. I'm going to let you up right now. Ms. Robbins, are you currently having any diarrhea?
No, but really haven't eaten much lately either. When I was at home, I would only have diarrhea if I ate fried or fatty foods, so I usually try to avoid them. I guess I'm lucky that way. I understand many people with HIV have chronic diarrhea.
Mm-hmm. If you do have any diarrhea while you're here, just let me know. I can contact your doctor, and maybe he can give you something to help relieve it. Do you need anything right now? Do you need to use the bathroom?
Not right now.
Okay.
Keep in mind that 50 to 90% of patients with HIV infection and AIDS have chronic diarrhea, which can lead to chronic fluid and electrolyte imbalances, perianal skin excoriation, and weakness.
When you're ready, let me know, and I'll help you use the bathroom, because we need to take the oxygen with us, and I want to make sure that you're steady on your feet.
Okay, I'll let you know.
I'm just going to go get your morning medications, and then I'm going to let you rest for a while. Throughout the day, I'm going to come back and do more assessments with rest periods in between, and that should really help with your tiredness. Okay? In the meantime, if there's anything that you need before I come back, your call button is right here. If you press it, it'll alert me at the nurse's station, and I'll come right in and see what you need. Okay?
I appreciate that, but now I'm really very tired.
Okay. You get some rest, and I'll see you in a little bit.
After completing your assessment, you will return all of the equipment and promote good infection control practice by washing your hands. When compiling your report, keep in mind that by noting trends from one assessment to the next, you can provide helpful insights for the patient's care. The final step of your patient visit may be to develop your nursing diagnoses. Based on your assessments, the nursing diagnoses for this patient could include imbalanced nutrition, less than body requirements, activity intolerance related to hypoxia, and ineffective airway clearance related to Pneumocystis pneumonia. Thanks for watching this video on caring for the patient with HIV/AIDS-related Pneumocystis pneumonia. Be sure to also study the instructions in your textbook.
Now we continue. Symptoms. At first, PCP may cause no symptoms. Call your doctor right away if you have any of these signs or symptoms of PCP. It can be FARA, fever, mild and dry cough or wheezing, shortness of breath, especially with activity, rapid breathing, fatigue, major weight loss, and chest pain when you breathe. PCP is still the most common opportunistic infection in HIV-positive people. Those with a CD4 cell count less than 200 are at highest risk. 30% to 40% of HIV-positive people develop PCP if they wait until their CD4 cell count drops to around 50 to receive treatment. PCP is still a major cause of death in AIDS patients in the United States. PCP is a very treatable and preventable infection. This is application medicine. Here we have another video.
You could quickly discern that this was a lung that we are dealing with, which I think you will agree it is. Then you can also quickly discern that it is a very significant pneumonia as well, because all of those alveoli are infiltrated with some type of inflammatory cell. There's some pink stuff there. And notice that it involves the whole portion of lung here diffusely without any particular focal destruction of the lung. It's almost as though all of these alveoli just were suddenly loaded up with junk. And let's take a look at the junk, or we could go home and just call this pneumonia. Inside the alveoli, you have, once again, we can add to our diagnosis of pink, granular, or perhaps hyalinized junk. We know that it could be fibrin. We know it could be proteinaceous debris. We know it could be amyloid. We could know perhaps it could be immunoglobulins. We know it could be necrosis. But let's add one more thing to our list, because if you notice that in almost all of these alveoli, like here, and here, and here, and here, and here, that if you look very, very closely at these pieces of fuzzy pink stuff inside the alveoli, if you had a good imagination, you would say, well, not only is this kind of fuzzy, but perhaps maybe there are little round things inside here as well. And indeed they are. They describe this as the woolly, W-O-O-L-Y, exudate of Pneumocystis carinii. This is Pneumocystis carinii pneumonia. Ironically, the radiologists also describe the lobes of lungs, which are infiltrated diffusely as woolly as well. So however you want to imagine the wool, you can, either radiologically or pathologically. If you were to do a silver stain on any of these little areas of woolly intraalveolar exudates, like I'm going to do here for you instantly, you will see that indeed some of these areas inside these woolly exudates, which look like they might have a little texture to them, actually do stain intensely with methenamine silver stain. These are the organisms. These are the protozoans, or perhaps other unicellular taxonomic entities. They stain more like a fungus because they're taking up the silver stain. But the classical organisms of Pneumocystis pneumonia, which is Pneumocystis carinii, look like little refractile. I've heard the word bent coins used a lot. In this particular area, they don't look too bent, but here's a little bent coin, and perhaps that's a little bent coin. But most of these coins don't look too bent. But if you, this is a particularly very ideal, nice stained areas. In some areas, they look a little bit more bent. Also notice that there may be some organisms here that are not taking up the stain too well either. But in the old days, and perhaps even now, the methenamine silver stain for pneumonias, which had a woolly intraalveolar exudate, was diagnosis for pneumocystis. Before the AIDS epidemic, these kinds of pneumonias were almost unheard of. Now they're the single most common type of pneumonia with AIDS patients. Now it's so prevalent that AIDS patients take antibiotics for pneumocystis even as a preventive measure, because they are all assumed to have some in their lungs, even if they're not quite clinically infiltrated or pneumonic yet. Thank you very much.
Now we continue. Pros. It has a treatment. If you develop PCP, you are likely to take Bactrim, Sectra, or Cotrim. These drugs are a combination of two antibiotics, trimethoprim and sulfamethoxazole, or TMP-SMX. Before HIV medication was available, PCP occurred in 70% to 80% of HIV-positive people. The number of cases has decreased a great deal. This is due to highly active antiretroviral therapy and PCP preventive drugs. Here we have another video.
Pneumocystis pneumonia, also known as PCP or pneumocystosis, is a form of pneumonia that can be life-threatening. It is caused by a yeast-like fungus known as Pneumocystis jirovecii. It had previously been incorrectly classified as a protozoan. This pathogen is specific to humans and has not been shown to infect other animals. Its former name, Pneumocystis carinii, is still in common usage. As a result, Pneumocystis pneumonia is also known as Pneumocystis jirovecii pneumonia and incorrectly as Pneumocystis carinii pneumonia. Pneumocystis is commonly found in the lungs of healthy people. Since it is a source of opportunistic infections, it can cause a lung infection in people with a weak immune system. Infections are frequently found in people with cancer, HIV and AIDS, and in those that use medications that suppress the immune system. Since the beginning of the AIDS epidemic, it has been closely associated with PCP infections. Pneumocystis jirovecii is found worldwide. Some reports show that 75% of children by the age of 4 are seropositive to the microorganism. This suggests a high background exposure. The concept of human-to-human transmissions of the fungus has been gaining recognition in recent years. Symptoms of PCP include fever, non-productive cough, shortness of breath, weight loss, and night sweats. The fungus can also invade other visceral organs, including the liver, spleen, and kidney. This only occurs in a minority of cases. These are just a few things to know about Pneumocystis pneumonia or Pneumocystis jirovecii. To learn more about preventing environmental infectious diseases and pathogens, or indoor air quality testing and consulting services, please visit the website shown on the screen.
Now we continue.